Welcome to Gracefully Graying. I am your host, family law attorney Henry Gornbein, and also a partner in the law firm of Lippitt O'Keefe Gornbein. Every week on Gracefully Graying, we explore issues that we face as we are getting older or have aging parents. Today on Gracefully Graying, I'm pleased to welcome as my guest Dr. Leonard Kerwin, who's not only a dermatologist but also a specialist in Mohs surgery. Dr. Kerwin, welcome to Gracefully Graying.
Thanks for having me. You can call me Lenny.
I will. First of all, Lenny, tell us about your background and, first of all, what made you decide to go into this area? I think I know the answer to that, and your training.
So, born and raised locally in the Metro Detroit area. As you know, my father's a dermatologist, so I've been around it my entire life. After high school, I went on to the University of Michigan, followed by med school at Wayne State University. After completing med school, I did a year of melanoma research at Carmanos Cancer Institute, followed by my internship and residency in dermatology at Wayne State University.
And then you specialize in Mohs, and why don't you first of all tell our viewers a little bit about what the training is for that subspecialty and exactly what is Mohs surgery?
So, we do some Mohs surgery during our residency. However, after completing my residency and the boards, I went on to a fellowship in procedural dermatology and Mohs surgery, a one-year fellowship accredited by the ACGME, the American College of Graduate Medical Education, and the ACMS, American College of Mohs Surgery. And it was a one-year fellowship in the Philadelphia area, affiliated with the University of Pennsylvania, with a complete focus on the removal of skin cancer, the interpretation of the pathology slides, and the reconstruction of the Mohs surgery defect.
Now, Lenny, when I grew up, my friends, family, everyone, we loved the sun. We liked baking in the sun. I remember probably doing everything that's wrong, using things like oils-based tanning lotions and things, not worrying about the sun, sometimes getting burned. And now you have the gracefully graying demographic, those who are 50 and over. We're paying the price. And why don't you tell us a little bit about that and some of the problems with regard to exposure to the sun?
We hear this all the time, and we didn't know better. In terms of risks for developing non-melanoma skin cancer, cumulative sun exposure, so those burns you had as a teenager, will add up over time. As we age and the exposure becomes more and more intense, as the exposure becomes more and more over time, your risk of developing skin cancer, including non-melanoma skin cancer, the basal cells and the squamous cells, on sun-exposed areas, the back of the hands, the feet, the top of the ears, the face, increases over time.
It's interesting. I was at lunch with two friends, and we've been friends since high school, and both of them have had Mohs surgery. One on the top of his head, he's bald, the other one on his nose. So why don't you tell us about the various types of cancer that can develop? I know there's basal, tell us about the various types.
So the two locations that your friends had are very common, obviously. Many types of non-melanoma skin cancers. When it comes to the two most common, it's basal cell and squamous cell. Basal cell carcinoma is by far the most common, about 80% of all non-melanoma skin cancers. Basal cell carcinoma is the abnormal proliferation of cells from the basal layer or the bottom of the epidermis. They can present a number of ways, including non-healing wounds, pearly pink papules, a pimple that won't go away, anything like that. And they're very common throughout the whole body. Squamous cell carcinoma, the second most common type of non-melanoma skin cancer, can be a little more aggressive. It's about 20% of the non-melanoma skin cancers. They may present as these scaly red patches. Basal cells are locally aggressive. I often compare them to bulldozers. They're going to push their way out, and over time they're going to sort of eat away at nearby tissue, but they're not likely to metastasize. Squamous cell, less common, can be more dangerous over time and do have an increased risk of metastasizing or going elsewhere in the body if left alone or larger in size.
And what about melanoma?
So melanoma is occasionally treated with Mohs surgery, sometimes slow Mohs, a little bit more difficult to see under the microscope. That is, again, related to the abnormal proliferation of melanocytes. obviously more serious and more deadly than the non-melanoma skin cancers, responsible for about 9,600 deaths per year. Again, regular surveillance, being looked over from head to toe, and looking for these dark, asymmetric moles is always key.
Lenny, you said regular surveillance. How often should someone have a full body screening by a dermatologist?
So I'd recommend once a year, a look over from head to toe. For when we're going to wipe off the makeup, we're going to make a mess of the hair, we're going to get you in a gown and look you over from head to toe. Once you have your first non-melanoma skin cancer, your first basal cell or squamous cell, your chance of developing a second one at some point in your life is about 40%. So it may be more often after that, depending on how often you're getting these, perhaps every 6 months. When it comes to melanoma, we may be looking you over every 3 months for a year, every 6 months after that, and then once a year. And then other things that can increase your risk of developing skin cancers is immunosuppression, transplant patients. And these patients will need regular skin checks every 3 to 6 months.
Lenny, let's talk about the various procedures. You mentioned, there are a lot of non-invasive treatments that are useful. Tell us about some of these treatments.
So when it comes to the removal of skin cancers, basal cell, squamous cells, melanomas, and the such, there's the destructive methods. And those can be surgical excision or Mohs surgery. And then there's other methods. So for instance, depending on the subtype of skin cancer, you might hear the term ED&C, or electrodesiccation and curettage. And this is a procedure where very superficial or early skin cancers may be destroyed. Cancer cells are replicating quickly. They don't lock together the same way regular tissue does, and they feel different. They feel more like jello, more mushy. So this is based on a feel. The dermatologists will scrape the area and burn and scrape and burn and scrape and burn 3 times until they feel resistance. The cure rate for this is good for the right type of skin cancer. A cure rate between 88 and 94%, depending on the user. Those in practice longer do have a better cure rate just because they're used to the feel of these. Otherwise, there's cryosurgery, the liquid nitrogen spray. There's X-ray therapy. There is topical treatments, PDT or photodynamic therapy. There are creams like Aldera, Imiquimod, Effudex, 5FU, which again, all of these used in the right clinical context for early superficial skin cancers are very good treatment options.
How often do you see a patient where your opinion is that Mohs is the, required procedure?
So when we decide about the treatment option for a patient, we're looking over both the patient themselves, their age, their expectations, the restriction in activity, the type of cancer it is, and then the subtype from there. Because when it comes to basal cell, for instance, you can have superficial basal cells, you can have micronodular, you can have more aggressive ones. Now, defining who gets Mohs surgery has sort of been a difficulty in the dermatology world. And in 2012, the American Academy of Dermatology, the American College of Mohs Surgeons, and the American Society of Derm Surgery published the Mohs AUC, or appropriate use criteria, in an attempt to define who gets Mohs surgery.
Tell us about the criteria that you're looking for. What you're saying is that Mohs is, I guess, a relatively new procedure?
Well, Mohs has been around since the 1930s. Dr. Frederick Mohs at the University of Wisconsin came up with the surgery, and it's been modified since then, obviously. In 2012, in an effort to sort of define who gets Mohs, this 20-page pamphlet came out defining who gets it. And they give everyone a score based on the type of skin cancer, immunocompromised, immunosuppressed, and such. What it basically comes down to is skin cancers in areas of tissue conservation. So above the neck, the hands, the feet, the genitalia. Skin cancers greater than 2 centimeters in size. Skin cancers that are recurrent or have come back after an excision. Skin cancers in immunosuppressed areas. And things like that may meet criteria for the Mohs procedure.
Let's go through the procedure. First of all, you're going through criteria. You're meeting with a patient. How scary is it? I mean, because it's like, this is not something that can be easily excised by some of the other treatments you're talking about. So we're talking about something, Lenny, that's more serious, I guess, for lack of a better word.
Yes, and I hear that a lot, but it should be the most comfortable procedure the patient ever goes through. You should wake up that morning, take your normal medications, eat. Come to our office. We have our Mohs rooms. There's TVs, there's radios, there's coffee, there's snacks. It should be the most comfortable procedure you ever have. With that said, during the consult when patients ask about it, I don't have a lot of answers for them because a Mohs surgery is a preservative surgery. We're cutting out just what we need to be. And you may be in our office for 45 minutes to an hour. You may be there for 5 or 6 hours, however long it takes to get rid of the skin cancer.
So when you start the procedure, you don't know how deep you have to go. Is that a correct statement?
So the patient's going to come in. We're going to take the vitals, check them in. We're going to mark the area that we see and believe to be the skin cancer. We're going to clean it. We're going to have the patient verify the site. We're going to numb it up, and I'm going to remove what I see and believe to be the skin cancer. So probably a very tiny circle around the scar of the biopsy. After that, we'll bandage up the patient. They can watch TV, coffee, snacks, talk with their friends, do their work on the internet, whatever they need to do. And that's when the waiting game starts. So I'm going to take the tissue I've removed, as well as a map of the patient, down the hall to my Mohs lab. I am going to orient the tissue. Mohs is all about orientation and tracing the malignancy of the skin cancer. So I may put nicks at 12, 3, 6, and 9, paint them blue, red, yellow, green, and put exactly what I do there on the map. I will take that tissue, I will give it to my Mohs tech, who will freeze it in a cryostat to negative 30 degrees Celsius, process it, cut it, put it on slides, stain it, and then give it back to me to read as the pathologist. That's about a 45-minute wait for the patients. Ideally, I will look at it under the microscope, see all negative margins. So I may see some skin cancer, but I'll be able to look all the way around its top, left, right, bottom, and see that I have normal tissue and I've gotten around the skin cancer, and close it up. Worst case, there's still some more skin cancer, and I'll be able to trace exactly where it is. So I can tell you it's between blue and red, in which case we'll go back to the patient, we'll numb up the area between blue and red, and we'll remove that area. Mark it, orient it, start the process over again. So another hour for it to be frozen, put on slides, and allow me to read it. And this can go on 2, 3, 4, 5 times, however long it takes to get rid of the cancer. With that said, the average is about 1.7 cuts.
And so someone walks in, knows the procedure is going to happen, but until you're in and cutting away, and I guess it's almost like you're peeling an onion, for lack of a better word.
It's a great analogy, yes.
And so you're cutting down layer by layer, and this must be on a microscopic basis, until you get to the, hopefully excise all of the malignancy, and there's a clear area around. Is that kind of a basic lay person's explanation?
It is. Under the microscope and the tissue, everything's done in nanometers. We're cutting, obviously, with our naked eye. So we are taking out the epidermis, the dermis, possibly down to the fat. So that is done, but again, we're keeping it as small as we can and preserving as much normal tissue as we can.
We've reached our first break point. We're going to be right back with my guest, Dr. Leonard Kerwin, dermatologist and Mohs specialist, right after this break.
Welcome back to Who's Got Chutzpah. I'm your host, Rabbi Tzvi Jacobson. Andy, are you ready? Andy, what holiday is this associated with?
Oh boy, Sukkot?
I'm sorry, that's not the answer we were looking for. Whitney, for the win. Can you tell us which holiday is this?
I know. Shavuot.
No, I'm sorry. I've got the answer. Ta-da!
What?
My show, Let's Talk Torah, where we talk Torah, holidays, faith, and all the things that help us live our life. That's Let's Talk Torah, Thursdays at 3 p.m. on newradiomedia.com.
That's pretty good.
A gelling agent used in making jams and jelly may have anti-cancer properties. Now, anyone who's ever made jams or jellies is familiar with the ingredient known as pectin, which is a natural fiber product found in most fruits and vegetables. A group from the Institute of Food Research in the United Kingdom found that under the right conditions, pectin releases a molecular fragment that binds with a protein that inhibits cancer growth. And the thing that may make jam and jelly more effective at slowing the growth of cancer than raw pectin is the process used to modify it for use in jams and jellies. You see, it turns out that the modification helps to emphasize the release of the cancer-fighting fragment, which is known as galectin-3. Now, most commercially available pectin comes from the peel or citrus fruits and apple pulp that is processed before its sale. So for now, no one knows if pectin found in unprocessed fruits and vegetables has the same cancer-fighting qualities. With another prescription for your health, I'm Dr. Jim Bragman.
At times we see a guy running down to first base, and it turns into a hobble.
Get umped. I mean, that's getting umped.
That can't be the same guy.
Can't be the same guy.
We are back with my guest, Dr. Leonard Kerwin, as we discuss issues with regard to dermatology and Mohs surgery. Lenny, before the break, you were really taking us through the procedures of Mohs surgery. And you were talking about various colored slides, but before you go there, I'd like to digress for a minute and let's talk about, why don't you explain to our viewers exactly what a biopsy is and how that works?
So when I'm seeing the patient for Mohs surgery, they've already been diagnosed. The spot, the lesion, has already been biopsied by myself or another dermatologist or physician. A biopsy is strictly to make a diagnosis. A biopsy cannot assess margins, tell you if it's all out. A biopsy is done easily at the skin checks often, or a patient comes in complaining of a changing, bleeding, different kind of mole, or the physician finds something like that. And it's simply numbed up and shaved off typically. A very tiny sample just to make a biopsy, just to make a diagnosis.
And you were mentioning before the break about the fact that various colors show up on the slide when you're doing the Mohs procedure. And explain what the difference of the colors mean.
Well, I'm putting some of those colors on there. I'm putting NICs at 12, 3, 6, and 9 to orient the tissue, so I know what's up on the patient, down on the patient, all that. With that said, the slides are stained with hematoxylin and eosin. They do have a purple to blue color to them. But again, the biopsy has made the diagnosis. Once the diagnosis is made, my job as the Mohs surgeon is to see if any of the skin cancer remains, the basal cell, the squamous cell, the diagnosis the patient already has, and to really establish normal tissue all the way around it.
Now, you mentioned it could be a 45-minute procedure, it could be a multi-hour procedure, and I guess it depends on how deeply you have to cut into the skin. If you have to go deeply, I had a friend, I think he had to come back more than one day. Does that ever happen?
Very rarely. As I said, the average is 1.7. The vast majority of times, the skin cancer is going to be removed, the wound is going to be closed, sutured together, allowed to heal on its own. It's going to be a one-day procedure. With that said, things happen. There are some that are more aggressive. There are some that go down to bone or periosteum that do require we send you somewhere else for radiation or oculoplastics for a repair. So those kinds of things do happen, though rarely.
And what about, you've cut down, is there ever a need for plastic surgery, or it's just something that you suture it up and it heals on its own, basically?
We have a number of options when it comes to repairing the defect, and we're going to do it in the most cosmetically elegant way we can to give you the smallest possible scar or wound. Because with Mohs surgery, we're tracing the skin cancer, the wound is going to be as small as possible. We're going to preserve as much normal tissue as we can. We're going to trace it just left, right, top, bottom, deeper, where we have to go. Very, very small wounds may be allowed to heal on their own, a secondary intention or granulation. Wounds a little bit larger on the cheek, scalp may be pulled together in a linear fashion and have a fine line that heals very well. Or larger defects or areas where there's not as much loose skin, like the ear, the nose, that may require a graft or a flap. So we're going to do whatever it is to give you the best cosmetic outcome once we have looked at 100% of the specimen and made sure that the skin cancer is out.
What about cost factors? Are there economic factors involved?
So Mohs surgery is covered by insurance. Once you've hit the deductible, it's all covered by insurance. You have a diagnosis of malignancy. When we look at Mohs surgery versus the alternative, an excision, for a non-melanoma skin cancer. And an excision, we just sort of cut all the way around it. For a basal cell or a squamous cell on the arm, chest, back, shoulder, less than 2 centimeters in size, we're going to cut a 4 millimeter margin out of it. And 95% of the time, we will get it all out. We may get a little bit extra out because we're not tracing it like Mohs, but we're going to get it all out. When you look at the cost of these, it's difficult to compare apples to apples. You're looking at Mohs surgery with a 99% cure rate, where the surgeon is removing the tissue, reading the slide, and putting it back together. You're going to compare that to an excision with a 94, 95% cure rate. So you may need a second cut down the road, a few weeks or months down the road. The specimen's being sent off for a second physician, a pathologist, to read the specimen, and it's being closed as well. So you're looking at one upfront fee for the Mohs surgery to the practice, the Mohs surgeon who's the pathologist, and removing it and putting it back together, as opposed to an excision where there is a fee for the removal and closure, but a separate fee to the pathologist.
Then why wouldn't just about everyone opt for Mohs if they're giving a choice?
Again, the appropriate use criteria came out to sort of define who gets Mohs. It's a great treatment option. It's going to give you a better cure rate. With that said, an excision is more than adequate the vast majority of the time, especially on the abdomen, back, shoulder, where there's plenty of skin laxity.
Now, if someone has had Mohs surgery or, some type of skin cancer, are the chances of it returning in another place greater than someone who's never had it?
So, in terms of returning, the Mohs surgery is a 99% cure rate. We're looking at 100% of the tissue. That cancer will be and should be gone when you leave the office that day. With that said, genetics, cumulative sun exposure, all those things, it's affected your whole body. So once you've had your first non-melanoma skin cancer, your chances of developing another one is 40%. So you have to be diligent. You have to know the warning signs, things to look out for, and get those skin checks at least on an annual basis.
Are there any disadvantages to Mohs surgery? I mean, you've given some very positive pros. Are there any cons?
It's an unpredictable day. As I've told, I don't know how long you're going to be in my office. You could be there an hour, 2 hours, 3 hours, 4 hours, 5 hours. I don't know how long you're going to be there. Otherwise, obviously, as a Mohs surgeon, I'm a little biased. I do think it's the best treatment option out there. With that said, there are other treatments that are more than adequate for very superficial, very early skin cancers. There's nothing wrong with the ED&C, the liquid nitrogen, the topical therapies like Efudex or Aldera. For a small skin cancer on the arms, on the back, on the chest, an excision is more than adequate. And it may not change the outcome with those margins, and the closure may look very, very similar.
Now, there's certain ages where we're more prone to getting skin cancer. I mean, like someone in their 50s, 60s, 70s, does the rate of cancer appearing increase as we age, or what are some of the factors there?
So it's about cumulative sun exposure. So obviously, the longer you live, the more time you've been in the sun, the increased risk of developing it. With that said, I've seen people in their early 20s. The tanning bed increases the risk of developing basal cell, squamous cell, and melanoma exponentially. Areas that stick out, the top of the ears, the top of the scalp, and someone losing their hair, those kinds of areas really stand out. And when it comes to preventing these, there's only so much you can do. Wear hats, wear your sunscreen, but sunscreen's only good for 3-4 hours. You got to reapply it. If you're out there for 18 holes, at the turn of that 9th hole, you got to put on some more sunscreen.
What other advice would you give to our viewers to, I guess, stay out of the sun as much as possible, but what else?
Well, obviously sun protective measures. Everyone's protecting their children, everyone's making sure their kids are wearing sunscreen. Put it on yourself. Protect those areas that stick out, the top of the ears, the bridge of the nose, the back of the hands. Be careful and always wear sunscreen. You're getting more sun exposure simply being in the car, walking from parking your car inside a building. Sun exposure is all around you. It happens in the winter. It's reflected off the white snow. Get a moisturizer with built-in sunscreen and protect yourself. And don't be shy. Get a skin check. If you notice a spot not behaving like it should, if you have a pimple that's there for 3-4 months, go in and get it checked out. It may not be just a pimple.
Now, cloudy days, that doesn't protect you. There's still ultraviolet rays coming through, correct?
There's always UV radiation.
And I've also heard if you're driving your car, you're still not fully protected.
You're not fully protected, and we see more skin cancers, malignancies on the left side here just because of the window. We see there are studies showing increased risk of skin cancers in pilots, just up higher with more UV radiation. We see it increased in people soldering on the side of their face from the heat and the light there. We see studies showing increased risk of skin cancer on the legs in people doing controlled fires in California, just with that constant radiation and heat and everything on their legs.
What is some other advice that you could give to our viewers just in the area of dermatology in general?
Well, as a Mohs surgeon with a focus on skin cancer, it's always about sun protection, avoiding the sun, being careful. Everyone knows the A, B, C, D, E, the asymmetry, the border, the color, the diameter, and E is the evolution or the change. But things behaving like they shouldn't. I hear all the time someone coming in saying you've had a rash for 6 months and it won't get better. It's not changing like the other one, or a pimple that's lasted so long, or a scratch that isn't healing. Those kinds of things that aren't behaving like they should be checked out.
What do you find most gratifying or rewarding about this area of medicine?
Wow. I love what I do.
It sounds like it.
I love what I do. And being a Mohs surgeon with a specialty in Mohs surgery, I'm doing Mohs about 2 days a week, but I'm also doing skin checks and looking for these things. And I'm helping with acne, warts, and all those types of things. So, the smile on the patient's face when they're happy with the treatment, when the skin cancer's gone, when they can say they're now cancer-free, is always reassuring.
We're down to about a minute and a half. I'd like you to share, well, first of all, do you find any frustrations about this area of medicine?
I think a lot of physicians will tell you most frustrations insurance related nowadays, the high deductible plans and all that. But in terms of my everyday practice, I love what I do.
I know the paperwork is becoming overwhelming. What are some final thoughts you would like to share with us in this last minute or so before we sign off, Lenny?
As I've said, don't be shy. Get those skin checks. It's scary, but these are all treatable, preventable things if they're caught early. The worst thing you can do is put it off and delay the inevitable. A small defect is only going to grow. And by the time it comes back through a scar, through the biopsy, if you decide not to come in for Mohs, a small minor procedure becomes that much more of an ordeal. If you need anything, we have everything on our website, mishderm.com, as well as a video of Mohs surgery that you're welcome to see.
How do they reach you?
We have offices in West Bloomfield, Commerce, Novi, and Berkeley, 248-855-3366, or mishderm.com.
And, kind of a tagline that I'm thinking of that applies to you and to so many areas. It's like we as people, especially for those of us who are gracefully graying, I think it's important to be proactive and not reactive. And if you see something suspicious, don't wait. Contact a dermatologist at once. And I think that's very, very important. And you're in a very important specialty. And Lenny Kerwin, I want to thank you so much for being my guest on Gracefully Graying. And I want to thank you for watching Gracefully Graying. This is an important topic, and again, be proactive and not reactive.